Welcome. I'm Carol Jenkins, Executive Director of Cystic Fibrosis Research Incorporated, and you're joining us tonight for our CF Discovery Series. The CF Discovery Series was developed in collaboration with Camille Wasowich, nurse practitioner at Stanford, at the adult clinic there, and it was designed to make vital CF information accessible to the CF community. Before beginning, I'd like to note that no information presented tonight is intended for a patient's diagnosis or treatment. As always, we urge you to work together with your healthcare team for your medical treatment. Tonight, we're really looking forward to our presentation on cystic fibrosis at a gut level. Thanks to Genentech and Respirtech for supporting this important evening. Their support pays for the venue, the refreshments, the studio we've constructed here, and other costs associated with the program. Tonight's program is being produced by your CFRI Live team, Eric Martin, Scott Wakefield, David Suhu, and Joanne Davis, who is tracking questions from our online participants. We're here live at the Crown Plaza Cabana Hotel in Palo Alto, California, and I encourage you all to ask questions, whether you're here in the audience or part of our online community. Hello especially to those of you who are in the hospital and cannot join us. We're so glad that actually you can join us online. Finally, thanks to our volunteers for serving the food and helping us with our cross-infection guidelines. So, here to introduce our speaker, Dr. Wen, is Camille Wasowich.
Hi, thanks for coming. You know, we've had a lot of issues, not only with our CF pre, but also our post-transplant regarding GI motility and weight stabilization. So, because so much of your drugs are processed orally, it was important that the drugs are really being absorbed effectively. Constipation is not only a painful problem, but often it's a preventable problem, and when there is a problem, it definitely needs to be diagnosed. I had the pleasure of meeting Dr. Linda Nguyen probably about 6 months ago when she was working with one of our patients that had an incredible recovery thanks to a combination of therapies. When we send them to Dr. Nguyen, it's after multiple oral medications have not worked, and they've shown diagnostic tests that have been difficult for them to have good passage. Dr. Linda Nguyen had initially trained at UCLA for her medical school. She did her residency at CPMC, and she did her fellowship at CPMC. She initially worked there for 3 years and is currently on Stanford Medical Center for the past 4 years. She's board certified in gastroenterology and a great pleasure to work with. Dr. Linda Nguyen.
Good evening. Thank you for having me here today. So my background is in GI motility and how the gut works and how the gut doesn't work. And I did not get involved in the world of cystic fibrosis until I came to Stanford, originally helping to manage the post-transplant patients and then pre-transplant. So I've kind of learned things along the way. But my approach is that, you know, when I understand physiology of the gut, the rest of it can kind of come into play irrespective of the underlying cause of the abnormal physiology. What I wanted to do today was really go over sort of how CF can affect the gut. And it's divided into the luminal complications of cystic fibrosis, which is reflux, gastroparesis, meconium ileus in the babies, DOS, bacterial overgrowth, constipation, or rectal prolapse. Those highlighted in red are the ones I'm really going to focus in on. And those are the etiologies that we face as an adult gastroenterologist. And honestly, as an adult gastroenterologist, unless you're at a specialized center, you don't come across or take care of a lot of patients with cystic fibrosis. Then there's the pancreatic insufficiency and the hepatobiliary disorders, including gallstones and cirrhosis. I'm not going to touch base on too much because my area is more luminal, but it's something that we need to be aware of as we're caring for patients. So how does cystic fibrosis affect the gut? We all know about the pulmonary complications. The CFTR gene affects, as you know, chloride channel and regulates cell surface sodium and chloride, which is involved in the gut. There are over 1,300 mutations described, with the F508 being the most common. It's found in approximately 70% of Caucasians with CF in the U.S. In general, there's a poor correlation with the genetic, the genotype, the genetic mutation, and the phenotype. Although there are classifications of the more, serious genotype and the less serious genotypes in the gut, there are some genotypes that are associated with more severe disease, and I'll go over that as we go through the talk. But in general, there's not a good correlation. With the defect in the chloride channel, essentially what you end up with are thickened secretions, and it leads to impaired flow. That could be the bile, the pancreas, or the intestines. So let's talk about the luminal complications of CF, and we'll start at the top and move our way down. So GERD is a common problem, common symptom, both among the children and adults with CF. In children older than 5, it affects about 20 to 30%. In children less than 5 and adults, so you can see kind of the two peaks in the prevalence of GERD in the young child, less than 5, and in adults, where you can see up to 80% of individuals will have problems with reflux, and that could be heartburn, regurgitation, or even vomiting. The pathogenesis actually depends on the age. In children, the lower esophageal sphincter pressure is actually normal, so that's the valve between the esophagus and stomach. So the valve pressure is normal, but the relaxation of the sphincter is abnormal. So there's abnormal transient relaxation. So what the valve does is that when you swallow, it relaxes to allow the food to pass. And then with burping or increased pressure in the stomach, there's actually a relaxation of the sphincter pressure to allow the gas to pass. With reflux in children, as well as commonly reflux in the non-CF patients, it's this increased relaxation or abnormal relaxation of the sphincter that causes the reflux. In adults, it's a little bit different. The LES pressure is weak, and that may be due to hyperinflation of the lungs. So the lower esophageal sphincter pressure, there's an innate pressure, but it's also augmented by the diaphragm. So as the diaphragm moves lower down, then that actually stretches the esophagus, so the lower esophageal sphincter is not as strong. Some of the medications that are used, for example, like theophylline, can lower the lower esophageal sphincter pressure. You can see increased intra-abdominal pressure. So if there's increased pressure from the abdomen, either from chronic coughing or wheezing, that could increase the risk where acid or contents in the stomach comes up into the chest. Chest physical therapy. So a lot of the drainage therapies where patients are lying flat, or if you're upside down, the gravity will promote reflux. And the presence of gastroparesis or slow stomach emptying. So if the stomach is emptying poorly and the food cannot go south, it has nowhere else to go but north. As I alluded to earlier, the symptoms can vary. It can be heartburn, regurgitation, chronic cough, or hoarseness, even in the absence of the heartburn or regurgitation. And it seems, and the question comes down to, with reflux, is reflux associated with a decline in lung function? And the question is, which one's chicken and which one's egg? We do see that there is a correlation between reflux and exacerbations or pulmonary complications or pulmonary exacerbations. But the question is did the reflux cause the pulmonary exacerbation, or did the pulmonary exacerbation and the stressor of the exacerbation give rise to the reflux? It's hard to tell. Although in a subset of patients, it does seem that treating the reflux actually, so the presence of reflux worsens their symptoms, and treating the reflux actually improves their pulmonary symptoms. So I think you get into this vicious cycle. So how do you treat reflux? It's similar to the treatment of patients without cystic fibrosis. The proton pump inhibitors are the mainstay of therapy, but keeping in mind that any of the proton pump inhibitors, what it does is it just decreases the acid in the stomach. It doesn't prevent liquid or gastric contents from coming up. So if there is slow gastric emptying or gastroparesis, the blocking the acid in the stomach doesn't really help with the reflux. Avoidance of chest physical therapy after meals, so do it before eating. And for patients who fail therapy, especially those with regurgitative symptoms, so after one eats and bends down and feeling a food coming up into the chest or even to the back of the throat, those kind of patients you want to consider fundoplication if surgery is an option from a pulmonary standpoint. So what is fundoplication? It's surgical therapy. And so you see here that there's a picture of a normal stomach where, let me see here. This is the esophagus here. This is the lower esophageal sphincter. This is the fundus of the stomach. And what the surgeons do is they can do this laparoscopically. They take the upper part of the stomach and wrap it around 360 degrees. This is a Nissen fundoplication. And you see down here, this is a partial fundoplication where in some individuals where if there's presence of esophageal dysmotility, you don't want to do a full 360 degree fundoplication because then it will increase the risk of food getting stuck going down. The gastroenterologist and the surgeon may decide that a partial fundoplication is the way to go. And here's the difference here, where you see the wrap is 270 degrees instead of 360 degrees. And you can make the wrap either in front or in back, and it goes by the name of either door fundoplication or a toupee fundoplication. One doesn't seem to be better than the other. So moving out of the esophagus into the stomach, the next entity is gastroparesis, and essentially it's slow stomach emptying in the absence of mechanical obstruction. It does tend to be associated with more advanced lung disease and duration of diabetes. So diabetes in of itself, especially long durations of diabetes, 10 or 20 years of diabetes can cause gastroparesis. So when an individual with cystic fibrosis comes with symptoms suggestive of gastroparesis, I can't tell you if it's related to CF or the diabetes. Probably a combination of the two. The diagnosis of gastroparesis, it can't be made on symptoms. You really need an emptying test, something objective. The gold standard currently is called a gastric emptying scintigraphy, and it's a nuclear medicine test. One consumes basically egg beaters, toast with jam in a glass of water, and cooked in the egg beaters is a little bit of technetium. And over the course of 4 hours, we can see what percentage of the food has been emptied from the stomach. Normally, you would see less than 60% at 2 hours and less than 10% at 4 hours. So if an individual has, retention time percentages greater than 60 or greater than 10 at those respective time points, is considered gastroparesis. Symptoms that one can present with are nausea and or vomiting, which are the most common, fullness or bloating, early satiety, feeling like they can't finish a full meal, refractory reflux, weight loss, and in diabetic erratic control of the diabetes. So when the diabetologists are dosing insulin, there's the assumption that you get certain peaks of insulin with the emptying of food, but if you eat a certain amount of calories and the food sits there for a prolonged period of time and the insulin has already had its effect before the food hits the duodenum, then you get these swings in the glucose control where one can swing from too low to too high. So how does one treat gastroparesis? There's no cure, so it's really treating the symptoms and trying to increase the emptying. First and foremost, start with dietary modifications. When you think about, a gastroparesis diet, it seems like the most unhealthy diet in the world. My kids love that diet. It's a low residue diet, so low fiber, nothing green and leafy, no raw fruits, no raw vegetables, essentially carbohydrates and simple proteins. The high fiber foods like vegetables and high fat foods are slow to digest. When individuals have severe gastroparesis, if I do an endoscopy and look inside, if there happens to be food in there, it's typically vegetable matter that one sees. Eat small, frequent meals. So instead of sitting down eating 3 large meals, eat small, frequent meals throughout the day. I usually recommend 5 to 6 broken up. So take the total caloric need and divide it over 5 or 6 meals. And then symptomatic control. So if one is nauseated, antiemetics, neuromodulators. The problem with gastroparesis, especially in diabetics, is that it's think of it like a neuropathy of the stomach, where the nerves in the stomach do not function well. And so the neuromodulators, medications like gabapentin, or the tricyclic antidepressants like amitriptyline, Elavil, nortriptyline, these medications help modify the nerves in the gut, improving glucose control. So we know that when the sugar goes above 270, so if we take anybody who has normal stomach function, no diabetes, but we acutely make the sugar go above 270, we can slow the stomach emptying. And if it goes below 50, we can accelerate gastric emptying. So what you want to do is tighten the glucose control, keep it closer to the normal range, but definitely below 270. You can use medications to accelerate gastric emptying. The medications that are available, like Reglan, there are concerns with using Reglan long-term because of tardive dyskinesia. That's irreversible. Domperidone, which I call the cousin of Reglan, it's widely available in many other countries. It's not FDA approved in this country, but there are centers that you can get it under what we call an IND program. So you file basically forms with the FDA, and you're allowed to prescribe the domperidone legally, just following certain parameters, which we were able to do. Erythromycin is an antibiotic that increases gastric motility, and there have actually been studies using erythromycin in CF with gastroparesis that has shown some benefit. The trouble with erythromycin, especially in the post-transplant period, is that it can interact with a lot of the transplant medications. It affects what we call the P450 system, and it can change the levels of some of the medications. It can also cause problems with QT prolongation, increasing the risk of arrhythmias. Azithromycin, which is newer, similar to erythromycin in terms of increasing gastric motility, less problems with the P450 system, less problems with interactions. Both of these medications, so the concern is the long-term use of the medication develops tachyphylaxis, or the body gets used to it. So use short courses of this. So usually, if I'm going to use it, I'll use it in the hospital setting, or I'll use it for, at most 1 month on, and then stop for, 2 to 4 weeks, and then you use another month. So you need to have kind of a holiday so that the medication can be more effective. The trouble with accelerating gastric emptying is that in the non-CF patients, accelerating gastric emptying has not been associated with symptom improvement. So if somebody has an abnormal 4-hour of, let's say, 50%, and I give them Reglan, and their 4-hour gastric retention drops down to 9%, they may still be just as symptomatic. However, in individuals with cystic fibrosis, pre or post-transplant, the reason I'm interested in accelerating gastric emptying is less so related to nausea or kind of abdominal pain or fullness. It really has to do with the severity of reflux. So if you increase the rate of gastric emptying, there's less food in the stomach to reflux, so it may decrease the severity and the frequency of the reflux. So moving out of the stomach into the small intestine, I'm going to talk about the DOS, or distal intestinal obstruction syndrome. And I'm going to differentiate this from constipation, which sometimes kind of gets melded into one. It's an acute obstruction where it's partial or complete of the ileocecal junction. So that's the junction where the small intestine connects to the colon. And when I say acute, it's just that. Find one moment and then the next moment with nausea, vomiting, abdominal pain, and distension. No warning. So, the day before, moving bowels, just fine. This affects 10 to 47% of patients with cystic fibrosis. The symptoms, like I said, are nausea, abdominal pain, and even in severe cases, you can feel a mass in the right lower quadrant here. So this triad of nausea, abdominal pain, and right lower quadrant mass, if you do an x-ray, it'll be very consistent with DOs. You can diagnose it with an x-ray or a CT scan, and what you see is this bubbly stool here. So this is stool, and that bubble is basically fat that's mixed in. So due to malabsorption, the stool becomes very viscous, and it gets essentially stuck at the junction between the small bowel and colon. And everything that's upstream from here becomes quite dilated. So all this here is that bubbly stool that you see, and the small intestine is dilated there. Usually the small intestine should be about this diameter and this diameter here. So risk factors. The genotype F508 is associated with higher risk of DOs. Age. So as one gets older, the risk of DOs increases, and the cutoff is about age 20. Pancreatic insufficiency is associated with DOs, and the reason being is that you get pancreatic insufficiency, which equals malabsorption, and the malabsorption is what causes the stool to be thick and inspissated. Dehydration can trigger this, so one's doing fine and then go out and run a marathon, get dehydrated, that can trigger DOs, or there's a heat wave, not drinking enough water, and again, think about it as with dehydration, the body's trying to hold on to fluid, so it's drying out the stool, and so that can increase the risk of DOs. Any prior history of DOs, so once you've had one, you're at risk for further episodes. Transplant is associated with DOs, and not sure why, not sure it's the medications or because of transplant with the improvement in lung function, the life expectancy is longer.
Because so many of the transplant patients were Delta 508, they were pancreatic insufficient, they were diabetic, now I've thrown steroids on top, and if they're having an acute rejection, I'm doing the high-dose steroids. So because of that, it throws them usually into that.
Yeah, I mean, the transplant, it's a combination of the transplant medications, and also, transplant in itself is associated with vagal nerve injury, and the vagus nerve actually controls motility of the gut starting from the esophagus down to the right colon. So it stops at the sort of halfway of the colon. Interestingly, DOs is not associated with pulmonary exacerbations or severity of lung disease. So it's not that as the lung gets worse, there's greater risk of DOs. They occur, unaffected by each other. So treatment of DOs really depends on if you're dealing with a partial obstruction or a complete obstruction. How do you know if it's partial, or how do you know if it's complete? A partial obstruction, one's still passing gas. So if you're still passing gas, that means things are moving through. Or if you're able to have a bowel movement despite the distension. A complete or high-grade obstruction means that there's nothing coming through, so there's no gas, no passing of gas. So with a partial obstruction, because there is room for things to move, you can use an oral laxative, most commonly Go Lightly or Miralax, that you mix in a gallon of fluid, and that basically you're creating your own Go Lightly that tastes a little bit better. So if you go out and buy a bottle of Miralax and you take 4 liters, of your favorite drink, it actually is easier to go down than the pre-made Go Lightly, even with the flavor pack. For the high-grade obstruction, you don't want to give things from above, because then you're just putting, more in, and it's pushing up against a complete blockage, and you're going to cause more problems with nausea and vomiting, and actually potentially risk perforation because you're over-distending the bowel. So for a complete obstruction, you want to go from below. And the gastrographin enema is diagnostic as well as therapeutic. There's a little bit, the gastrographin allows the radiologist to see where this water enema is going, and they can see it flow into the small intestine above the area of blockage, and because it's such a high volume, it kind of flushes the stool out. For very severe obstructions with the distension, an NG tube will help decompress. It will help with the nausea, vomiting, decrease the risk of perforation. And then surgery if there's evidence of peritonitis, which means that there's been a perforation, so fevers, severe pain, or tenderness. And you can see that on imaging if there's any inflammation or air where it doesn't belong. So how do we prevent this from recurring? Because most of the time, this requires a hospitalization, a couple of days to get everything cleaned out. So what's most important is prevention, and you want to look at adequate pancreatic enzyme replacement. Are we preventing fat malabsorption? Because fat malabsorption is the key to DOs. So if someone is having, problems with recurrent DOs and they're taking all their enzymes, then the question is, well, then why are the enzymes not working? And then we'll have to kind of troubleshoot as to why that's the case. And I'll go over a little bit later some ideas or some thoughts as to why pancreatic enzymes may all of a sudden not work. Use laxatives and stool softeners. Again, trying to prevent the drying out of the stool, trying to prevent things from getting inspissated. So now contrast DOs with constipation. Constipation is more of a gradual onset. So where, with DOs, you see an abundance of stool in the, terminal ileum, which is the end of the small bowel, and the cecum, which is the beginning of the colon. With constipation, you see stool throughout the colon. So you see it on the left as well as the right, evenly distributed. And it's a gradual onset, so that each day there's been less stool output. The severity of the constipation does increase with age, so you'll frequently hear, well, I didn't have this problem, 5 years ago, but I do now. And it's probably a combination of the CF effects on the gut, but also the gut with age slows down. So there's slower motility as we age. So someone who is 80 without any other illnesses, their gut motility will be slower than someone who is 50. So treatment. You've got laxatives and the stool softener. So the most common and typically the first ones used are, polyethylene glycol or Miralax, Docusate, or lactulose. And those essentially increase the fluid content in the stool. Amitiza or lubiprostone is actually FDA approved to use initially in idiopathic constipation and then in IBS. And what it does is it activates type 2 chloride channels, the CLC2, which is not affected by the CFTR mutation. So it's a chloride channel that is functioning that can be stimulated using this medication. And what it does is it increases the intestinal fluid secretion. And by increasing secretion, it increases colonic motility. There was only one pilot study of using Amitiza in cystic fibrosis. I believe it was 10 or 12 patients for a 1-month study, and there were a number of case reports. 5 patients with cystic fibrosis who were treated with Amitiza. And in the case series, it seemed like there was benefit. In the pilot study, there was less of a benefit, but what they did was they had patients either take their Miralax and Docusate in one arm, or they stopped the Miralax and Docusate and added just the Amitiza alone. And I don't think the lubiprostone alone is going to help with this, so it's really a combination. Using the lubiprostone along with a stool softener. Misoprostol, it's really, really old medication. It's a prostaglandin E analog. It actually helps it was originally used to help prevent and treat gastric ulcers. So it helps, it actually creates a lining, not a lining, but a mucosal barrier in the stomach. It also decreases the acidity in the stomach as well as in the duodenum. But we also found that it increases colonic contractions. We don't use it a lot because it also induces uterine contractions. So in constipation typically affects women more commonly, and we don't want to be using a medication that can induce uterine contractions in young women who may get pregnant, because it is actually an abortifacient. So we use it with caution, but it works quite well in increasing colonic contractions. And I'll also talk about that later and how to use that in pancreatic insufficiency also. So you can get a 2-for-1 with that. So moving on to something else that can affect the small bowel is the small intestinal bacterial overgrowth, or SIBO. And what it is it's increased bacteria concentration in the small intestine. So we all have bacteria in our mouths, we all have bacteria in our colons. This is just bacteria in a place it doesn't belong. In the setting of cystic fibrosis, it's likely due to the slower motility and the decreased secretion. So the secretions in the small bowel essentially clear away the bacteria that we swallow on a daily basis. The symptoms can vary. It can be as minor as bloating, but it can cause malabsorption of nutrients as well as bile salts and weight loss. It can also cause the pancreatic enzymes to not function as well. So if you have someone who has been doing well and all of a sudden now they're having more problems with malabsorption, look into bacterial overgrowth. You can the diagnosis for bacterial overgrowth is a simple test, time-consuming but simple. It can be done with several different breath tests, but the concept here is that here's a small intestine, and if there are bacteria in the small intestine, a sugar that one consumes will go into the small intestine, and the bacteria will ferment that sugar and produce hydrogen and or methane gases, and you can pick that up in the breath. So depending on the pattern of the rise in the hydrogen or methane level, one can diagnose bacterial overgrowth. You can also go in and do an endoscopy and take a jejunal aspirate and culture it, much more cumbersome to do, and you may be sampling the wrong area. So it's done more for research purposes, but the breath test is much easier and much more commonly done. And again, if you look at why is bacterial overgrowth significant? If you look at the concentration of normal bacteria in the gut, there's very little in the stomach and small intestine, and the concentration gets higher as you get to the lower small intestine and the colon. And these are the various, good and bad bacteria. And so when one's been on, antibiotics for, multiple courses, not only are you killing the good bacteria, you're also killing off not only are you killing the bad bacteria, you're also killing off the good bacteria. And that alters kind of the functioning of the gut. So moving on to pancreatic insufficiency, it's the most common GI complication of CF, and because of the poor flow of the pancreatic, basically the pancreatic juices, the pancreatic enzymes, it causes sort of an autolysis or autodestruction of the pancreas, and that leads to the sort of what we call the exocrine dysfunction, the malabsorption, and the endocrine dysfunction, the diabetes. It affects up to 90% of patients, and approximately 60% of infants already have pancreatic insufficiency, so a lot of this is occurring in utero. It does correlate with genotype and severity of the pulmonary function. So manifestations of pancreatic insufficiency, you have steatorrhea or the oily stools, malabsorption of fat-soluble vitamins A, D, E, and K are the four main ones. Osteoporosis due to malabsorption of calcium and vitamin D, weight loss or failure to thrive, diabetes, and we talked about earlier the DOs. How do you diagnose pancreatic insufficiency? You can do a 72-hour fecal fat. So you eat 100 grams of fat and you collect the stool over 3 days, and you can measure how much fat is in there, but it's not specific for the pancreas. So, so fat malabsorption can occur if there's a pancreatic problem or a small intestinal problem. But you can actually do a much more simple test, the fecal elastase, which is a one-time stool test that quantifies the amount of the pancreatic enzyme being produced, especially in kids. It has very good sensitivity and specificity, meaning it's very accurate in diagnosing pancreatic insufficiency. And there are different cutoffs. So, less than 100 is severe, 100 to 200 is moderate, greater than 200 is normal. So if you have someone who has a normal elastase, they will not need pancreatic enzymes, but the pancreatic insufficiency can occur later in life, so it's something that you just want to continue to monitor, not say that at 15 the elastase was normal, at 30 it should never be repeated. So how do you treat pancreatic insufficiency? The mainstay are the pancreatic enzymes, which replacement with meals and snacks. And this is kind of the general rule, but of course it's a little bit, it changes depending on response and the meals that you eat. Children less than 4, the suggestion is 1,000 units of lipase per kilogram per meal. In children older than 4, and including adults, the recommendation is approximately 500 lipase units per kilogram per meal. It's slightly lower in adults, mostly because adults weigh more than children. The maximum dose should be 2,500 lipase units per kilogram per meal, or 10,000 units per kilogram per day. The reason being is that too much can actually cause scarring or fibrosing of the colon. So the pancreatic enzymes, if there's an overabundance of it and it gets to the colon, it can cause stricturing. So there have been a number of case reports of children and adults with cystic fibrosis who have presented with strictures in the colon. So there are different pancreatic enzyme supplements out there, and really there's only 3 available in the U.S. The top one is only available in Europe. They're all enteric coated, so enteric coated prevents the breakdown or activation of the enzymes in the stomach, because you want the activation in the small intestine. And there's different combinations of protease and amylase with the various compounds. There have been no studies to say one is better than the other in pancreatic insufficiency or in cystic fibrosis. It's really sort of trial and error to see which formula works best for you. So then, when the enzymes don't work, what do you troubleshoot? What are things we can troubleshoot? So gastric acidity. So acid can inactivate the pancreatic enzymes. So the enteric coating can protect the enzymes. However, if one has gastroparesis, that means the enzymes will sit in the stomach longer, which is more time for the gastric acid to kind of break down the enteric coating and the enzymes. Duodenal acidity. So with cystic fibrosis, with a decrease in secretions, now there's also a decrease in the bicarbonate secretion in the pancreas. So bicarbonate takes the fluid from the stomach that's acidic, combines it with the gastric fluid, and makes it more alkaline. And typically, pancreatic enzymes require pH greater than 5.8 to dissolve the enteric coating and make the enzymes available for use. So if the duodenum is acidic, then the enzymes kind of pass through without being activated. So it's taking enzymes, but really not. Bacterial overgrowth can cause the enzymes to not function well. Like I said, gastroparesis, and obviously lack of compliance, which you always have to delve into for one reason or another. There may be individuals who do not like or do not want to take their medications. So I didn't put it in here. I meant to do that in terms of linking back my prior comment about how misoprostol can help with pancreatic enzymes, is that, as I mentioned before, misoprostol helps by decreasing the acidity in the stomach as well as the small bowel. So if you have someone who has duodenal acidity as a potential problem, the misoprostol actually increases the pH of the duodenum and will make the pancreatic enzymes work better. So then moving on to nutrition, which is really except for the constipation and the DOs, everything else is about maintaining nutrition and maintaining health. And really what you want to do is prevention of weight loss. And in children, the target BMI is between 50 and the 50th and 80th percentile. It's rare to see an overweight or obese child with cystic fibrosis, but you want to watch for obesity and any complications from obesity. Below the 10th percentile, you really want to require nutritional rehabilitation. So, tube feeds and even potentially TPN, but more likely tube feeds. Between 10, and 50, really want to be careful and monitor carefully so that they don't drop below 10. In adults, you want the target BMI is 22, a little bit higher, 23 in men. A normal BMI is between 19 and 25. The 22 and 23 gives you a little bit more reserve. The caloric needs vary with the severity of the cystic fibrosis gene mutation. So the more severe the gene mutation, the greater the need, the greater the caloric need, and the degree of pancreatic insufficiency. So if there's severe pancreatic insufficiency, the requirement will be higher. So in individuals with milder forms of cystic fibrosis, the requirement is 100% of normals up to 150%. Kind of recommended monitoring of kind of nutritional status, monitor the fat-soluble vitamins. So because of the pancreatic insufficiency, vitamins, the fat-soluble vitamins are not absorbed very well. So those are vitamins A, D, E, and K. Vitamin K helps with clotting, so you can measure the ProTime. If the ProTime is normal, then the vitamin K by default is normal. If the ProTime is abnormal, that increases the risk of kind of bleeding, so coughing and kind of hemoptysis or kind of breaking a blood vessel and bleeding from that. E is interesting because vitamin E is thought to be an antioxidant, so could some of the inflammatory processes, especially in the lung, be related to a vitamin E deficiency? And then, looking at iron, calcium for calcium and phosphorus for bone health, because osteoporosis is so common among the cystic fibrosis community, and looking at albumin and prealbumin, which are indicators of nutritional status. So some of the daily requirements by age, and this is not for anyone of us to memorize, but it's just to have an awareness that the requirement for calcium, phosphorus, magnesium changes with age, and the requirement in general increases as we get older, especially for calcium and for bone health, magnesium and phosphorus. And then again, the fat-soluble vitamins A, E, and K. There are supplements that have a combined, A, D, E, and K combined as one. So in terms of nutritional support, you can, start by encouraging oral intake with increased meal and meal frequency, using oral supplements like the, Boost, Ensure, tube feeds. And tube feeds actually have been associated with weight gain and stabilization of lung function. And you think, well, why would tube feeds work better than oral supplementations if you're getting the same amount of calories? With oral supplements, you're kind of competing with eating. So you can only do oral supplements while you're awake. But with tube feeds, you can actually cycle it at night so that you're getting additional nutrition while you're sleeping. So there's no competition with eating. How do you manage pancreatic enzymes with tube feeds, which is a common question that I get. So it depends on if you're doing cycled, bolus, or continuous. And really what you're looking, with tube feeds, there are long-chain triglycerides with the complex triglycerides, and then there are the medium-chain triglycerides, which actually do not require pancreatic enzymes to absorb. So with the help of your nutritionist, you can look at the amount of long-chain triglycerides one's getting in that cycle of tube feeds, and average 1,600 to 2,000 units of lipase per gram of triglycerides, and then you divide it depending on what type of tube feeding. So if it's cycled, so you're just doing it at night, you give 2/3 or 3/4 at the beginning and 1/4 at the end of the cycle. If it's a bolus, you just give it like a meal. Give the pancreatic enzymes right before the bolus of the tube feeds. And if it's continuous, it's all 24 hours, then divide the total dose over every 4 hours or 6 doses. So just, some different nutritional supplements and sort of the companies, the grams of fat that are available. So there are a lot out there that are available, different tastes. So especially when you're dealing with kids, if they don't like one taste, you can try another company that may taste better. My favorite is the Scandi shake, but that's just my personal preference. I'm just going to switch that. So why is nutrition important other than the obvious? Is that nutrition correlates strongly with lung function. So you see here, looking at, and this is mostly in children with cystic fibrosis, you're looking at the BMI percentile over here, and the goal here is at the 50th percentile, and you look at the FEV1 that's predicted, and as you go over to the right of the curve where you're looking at a normal BMI, the FEV1 is in the closer to the normal predicted, and as you drop below the 10th percentile, the FEV1 drops significantly. So in summary, GI complications in CF are common. GI manifestations tend to worsen with age. GERD, pancreatic insufficiency, and poor nutrition are associated with poor lung function, and treatment is aimed at symptomatic control and nutritional support. And with that, I will end and take any questions.
Typically, we use Zithromax 3 times a week, 500 milligrams as an anti-inflammatory, but you also stated its utilization as an on-off therapy with regards to motility issues. Will that 500 3 times a week help in any matter?
I usually use 250 twice a day. So I break it up instead of the 500. More so just because of the half-life of Zithromax and in terms of the activity in the stomach. So with erythromycin, we usually dose it 4 times a day. Zithromax, which is a little bit longer acting, I dose twice a day.
Thank you, Dr. Nguyen. I have a question. I'm post, and my colon ruptured after my surgery, so I have a lot of scar tissue. But one of the things that you didn't mention was the cystic fibrosis enema. That works very well for me. Is that not common to do that anymore?
It's used. I don't use a lot of it, and I honestly don't know if that's a Stanford. I think it's just a Stanford thing that you can't get elsewhere. So I
Combination of D5W with lactulose, and then we also use a stimulatory agent, the inhaled mucomist, and then there's a third agent. But yeah, Elika, the other nurse practitioner, developed it because the solution that we had, the Fleet's enema and the other enema, tap water, just wasn't sufficient. And so in combination with the pharmacist, those 3 therapies seem to be the volume as a pre-agent to going to IR for the alternative enema.
Yeah, I mean, until I came to Stanford, I'd never heard of the cystic fibrosis enema, and I think it's just because it's really just a pure Stanford enema.
And I have a bunch of questions. Can I continue on, or am I limited?
Ask one more, and then we'll share
Okay.
questions for a minute.
The other thing is you didn't mention milk of magnesia.
Well, milk of magnesia is an osmotic laxative. It's quite harsh, and it's something that you can use on as needed basis. So if you're trying to get flushed out, but it actually is associated with dehydration because of the amount of diarrhea that occurs with it. So I use that more as kind of on a per patient as needed basis. It's not my prevention strategy, because with prevention you want something that is not so harsh that you take and you're not sure when it's going to have an effect, and you have to wait home until it does take effect.
Joanne?
I have a couple. I'm just getting another one in here. What are your thoughts on the use of products such as Cutrell in CF patients, or Cutrell?
Is that
Culturel.
Culturel.
Culture.
Probiotics.
There's an L missing. Okay.
So, there have been no specific studies looking at probiotics in CF per se. I'm a big fan of probiotics in general for GI health. There have been a number of different types of studies that have looked at sort of the gut flora and different aspects of GI health, including irritable bowel and weight. And so, one of the concerns about probiotics, which I don't think is really warranted, there's only been a couple case reports of this, is that it is a bacteria, and there's concern about sepsis or bacteremia associated with it. So the bacteria gets into the blood system. I looked into this about 4 years ago, and I've only saw 3 case reports of probiotics actually doing that. And these were in individuals who were immunosuppressed. So I would endorse it only with the blessing of the transplant or the CF team.
We find that most of our patients that are on triple or quadruple IV antibiotic therapy associated with the CF exacerbation benefit from being on Culturel or Lactobacillus at the initiation of the antibiotics, because when they're not, there seems to be a higher preponderance of people having overgrowth of C. diff, which is a natural bacterium in your gut, because your gut's sterilized by the antibiotics. And so there seems to be less problems because once they do become positive for C. diff, then they're on an oral antibiotic in addition to the IV antibiotics they're already being treated for. So for our therapy for CF, with exacerbations on triple or quadruple IV antibiotics, we do endorse some type of probiotic.
So Camille, I would add that if you're going to use probiotics, especially for C. diff, I would use Saccharomyces boulardii, which actually has been very well studied in the world of C. diff in terms of prevention and preventing recurrences. So I use a lot of Saccharomyces in patients who have had recurrent C. diff. So if they've had C. diff and I'm treating them with antibiotics for something else, I don't want the C. diff to come back, I'll use Fluorostor. And then even in patients who have had really bad refractory C. diff, you can do a tapering course of antibiotics and then use the Fluorostor to prevent that. So Fluorostor is the trade name for the Saccharomyces boulardii. And it's on the hospital formulary if you need to know.
I'd like to make mention of our coming newsletter, which will be out in about 4 weeks or sooner for you to access online. And we do have some research cited there that's as recent as we could find through our contributing writer, Laura Tillman, on probiotics with CF. So stay tuned to our newsletter. Are there other questions?
Yes. Do you recommend colonoscopies for CF adults or older adults? And if so, how often?
So I would recommend colonoscopies based on the sort of routine colorectal cancer screening, so age 50 for our first colonoscopy, and then depending on if there's a polyp or not. In terms of GI malignancies, there have been reports of increased hepatobiliary malignancies related to cirrhosis. So liver cancers in the setting of cirrhosis, there doesn't appear to be an increase in small bowel or colon cancers. However, if there is, a change in symptoms, so not screening for colon cancer, but more diagnostics. So if, someone's having more problems with DOs, the constipation was fine, but all of a sudden, out of the blue, becoming more challenging to treat, then at that point I would do a diagnostic colonoscopy.
I'm post-transplant as well, and since my transplant, it seems like I've tried several different types of enzymes, and they all seem to work too well. I get constipated with all of them. I'm down to the Zenpep 5,000, one per day pretty much, and it's still too much. I was wondering what's behind that, because if I don't take them, I have no other symptoms besides malabsorption.
Mm-hmm. So I don't think it's so much that the enzymes are working too well. I think that's the constipation is a function of the slow motility post-transplant, and to some degree the malabsorption is kind of helping things along. So if you treat the malabsorption, then you're unmasking what normally is the constipation.
I'm curious if you've read any studies or have any information about the effect of fiber making chronic DOs worse.
I haven't come across anything about fiber making making DOs any worse, but essentially, soluble fiber works to bulk the stool. So, and with DOs, the problem is that the stool is too bulky, and so in treating constipation, we use a lot of fiber, but even in non-CF patients, I think there's an overuse of fiber, because too much fiber can cause problems with bloating and gas just by itself. I tend to not use a lot of fiber in CF patients just due to the viscosity of the stool.
Okay, from the online audience, you mentioned repeated courses of antibiotics kill off good bacteria and affect functioning. Can you talk a bit about possible negative effects of this?
Negative effects of not having
The good bacteria?
the
I
good
suppose?
bacteria. So part of it is that the good bacteria help in terms of being anti-inflammatory, so it helps with some of the oxidative stress. So in terms of like bacterial overgrowth and bacterial flora, those with altered flora are more commonly more likely to have problems with like irritable bowel, so cramping, alterations in bowel habits. There was actually a recent study that was quite intriguing where they looked at doing stool transplantation in individuals who, you got a group of individuals who were morbidly obese. They received stool from a group of lean individuals, and then they got stool from, other obese individuals. And the obese individuals who got stool from the lean individuals actually saw weight loss. So there's definitely something into this gut flora that's quite intriguing. And they've looked at they can do chips and kind of categorize how much of certain bacteria are in the colon, and there are differences in people who have IBS, for example, and those without IBS. The exact mechanism of kind of, what exactly it's doing, people are still trying to tease out.
Can you talk about the use of Amitiza? I'm not going to be able to pronounce any of these right. Amitiza and Miralax in helping with GI mobility.
Yeah, so Amitiza, like I mentioned earlier, increases it stimulates the chloride channel. And by doing that, increases secretions in the small bowel. And by increasing the flow through the small intestine, and there's more fluid in the colon, that accelerates the transit time through the colon also. And with Miralax, it's an osmotic laxative, so it's just increasing the amount. By consuming Miralax, you're helping the stool or the lumen hold on to the fluid that's in there. So you can't use Miralax without drinking fluids, because that would just kind of dry things out. But the Miralax is a different mechanism of increasing flow through the gut. And so you're using two different medications with two different mechanisms of action, but the same goal.
As a kind of a follow-up to the question on the antibiotics affecting the bacteria, the good bacteria, is bacterial imbalances in the gut supposedly can affect the brain. Is there any chance of this here?
Oh, that's something that I'm not expert enough to get into that. That world, there's more data I call the Google literature than in the PubMed literature. There may definitely be something in that, but I don't know that literature well enough to comment.
In addition to the follow-up question regarding the Miralax and the Amitiza, I do those, but I also do the Mucomist with Diet Pepsi 3 to 4 times a day.
Mm-hmm.
With those three combinations, my stomach gets upset. Is it because of the fullness or all that medication, or it could be a combination of everything?
Probably a combination of everything. Mucomist by itself can in a normal stomach, all by itself, can cause nausea, and it does have an odd smell to it. But it does do some things similar to the misoprostol in that it increases kind of the fluid flow. So the theme with all these medications that it increases secretions in the gut.
I have just one more. I called to make an appointment with your office, and you're scheduled till January. Is Stanford or your department going to maybe get some additional help?
That is a great question. We are hopefully bringing on somebody come December or January. And I'm hoping one of our fellows will also come and stay on board with us, and definitely get more people who understand physiology of the gut, and go from there.
A couple more questions.
Are there strains of probiotics that are more recommended?
So for the gut, the strains that have been studied the most are Saccharomyces and Bifidobacterium strains. So Saccharomyces for C. diff and Bifidobacterium for IBS and bacterial overgrowth. Lactobacillus also, but I think between Lactobacillus and the Bifidobacterium, there seems to be stronger data for the Bifidobacterium species.
Okay, and then I think we have time for one more from the online audience. Okay. What are the causes of bloating where there is no evidence of insufficient enzyme intake? In other words, weight is maintained, etc. What treatments, medications do you recommend for relief?
Oh, that's a loaded question there. So bloating can be from, gastroparesis, so if there's slow stomach emptying, that can cause bloating. Bacterial overgrowth can cause bloating. Constipation can also cause bloating. And then diet. And one of my favorite teaching points to fellows and medical students is when I talk to someone and they say, "Oh, I eat a very healthy diet," that means they probably eat too much fiber. And so if you exceed 25 grams of fiber per day in your diet, that actually doesn't improve gut function, or it doesn't improve constipation any more than 25, but what it does do is it increases the bloating and abdominal discomfort. So my magic number, range for fiber is between 14 and 25 grams. If one has gastroparesis, it's less than 14.
I can't speak for whoever asked the question online, but I think the question about the brain might have been related to the toxin buildups as a result of a severe blockage or DOS and changes in behavior and stuff like that. Can you discuss that at all?
That I'm not familiar with, and I can't discuss that function, that part of it. But I think being sick in general, and nutrition, a lot of it has to do with nutrition. So if you're having multiple episodes of obstruction, not eating well, and poor nutrition, that's going to affect kind of emotional well-being as well as mentation and clarity.
There's a lot of mood swings associated with blood sugar instability. So when she was talking about the delay of the insulin's having its impact, but your gut has been delayed because you have difficult to control, especially when you're post-transplant and you're on steroids. I think that makes it really, really challenging. So I totally feel for your situation. For our CF and for our transplant patients, we say straight hydration is when you're getting into your car and you see the empty and the full. The clearer your urine, the closer you are to full, the less likelihood you're going to be to have problems with constipation associated with dehydration. Because sometimes the other issues, it's really hard to control over.
We had two questions on this subject. Can a gluten-free diet help resolve or avoid gut issues?
The answer is it depends. So if one has celiac sprue, which is a true sort of genetic gluten allergy where consumption of a gluten product causes destruction of the lining of the intestine, being a gluten-free diet does resolve the GI symptoms. Then there is the entity of gluten intolerance, which is much, much more common than celiac sprue. And the understanding of gluten intolerance is, is still limited and sort of in the infancy stage of it. It's more akin to lactose intolerance, where there's not damage to the lining, but, it's clear cut that you consume it, and there's probably some degree of maldigestion, malabsorption, and subsequent kind of GI symptoms. So avoidance of gluten can improve a lot of GI symptoms, but in someone without celiac sprue, I don't think it's going to make all the GI symptoms go away.
I wanted to ask a complicated question about CF and chronic pain.
Mm-hmm.
A lot of our CF patients do have chronic pain and have to take medications for that pain.
Mm-hmm.
And they are always running the fine line between love and hate with their bowels anyways. And the addition of the pain medication often slows down their motility. Can you talk about how you can pre-plan and make changes in your laxatives so that you don't end up getting constipated or DIOS from pain medications?
Yeah, so first, when it comes to chronic pain, I actually use very little opiates. And I mean, in my non-CF world, I deal with a lot of chronic pain syndromes, and I actually use the nerve modifying medications. So I use a lot of medications like gabapentin, Lyrica, a lot of the anti-seizure medications. And gabapentin and Lyrica is less associated with constipation, and you're dealing with sort of the nerve component, the kind of nerve component of the pain. So all pain essentially becomes, whether it's muscle, it becomes more nerve related. So I use a lot of those medications, but if you absolutely can't avoid the opiates, then you can increase the some of the medications. So you can increase the Amitiza preemptively, or there are actually injectable medications that block the opiate receptors at the gut. So it doesn't block it in the brain. So the opiate receptors work, in the brain to give the kind of pain, to help with the pain effects, but the opiate receptors at the gut is what slows it down. So you can use methylnaltrexone, which is an injection. It blocks the opiate receptors at the level of the gut so that the opiates do not slow down the gut. It's an injection, though. So.
We have the opportunity for a couple of more questions. Does anyone else, and I'm coming to my our online friend Joanne, but before I take another online question, is there someone in the audience who hasn't had a chance to ask a question that you've wanted to? Joanne?
Okay, here's one that that I inadvertently missed earlier. How often would you recommend doing a clean out with Miralax?
No specific timeline or recommendation. Again, the cleanouts are harsh because you're really inducing severe diarrhea, and you're putting individuals at risk for dehydration, which can exacerbate problems with DOs. So I rarely recommend a clean out. Now, the scenarios when I would recommend a clean out is if someone is so constipated or obstipated they haven't gone for weeks. Start in that scenario. If you're starting Amitiza or starting any motility agent or laxative for prophylaxis, they don't work as well. So in that situation, I would give magnesium citrate, milk of magnesia, or Miralax, clean out to kind of get a fresh start, and then start the Amitiza. Now, for if it's a partial DOs, and they're having sort of the early obstructive symptoms before it becomes a complete obstruction, then I would do that on an as-needed basis.
Quick additional comment.
My concern, because I've had several people try colonic cleanouts on their own, and then they come in with an elevated creatinine, and incidentally they happen to be sick, and then they end up needing antibiotics, which I have to lower dose because now they're renally insufficient. So my goal, because when you do go for these like weekends up in Napa for cleanouts and stuff. My recommendation is not to. If you're having GI issues, to go and actually see your provider, because there's so many medications then can be really damaging either to your liver and or your kidneys, and either cause temporary or permanent damage. And the problem was that so many of our patients are diabetic because they are pancreatic insufficient. When their blood sugars start going crazy and they get dehydrated from high sugars, and then they put on these colonic measures, I think it causes more damage than actually helps.
Yeah, I mean, it's all, the key is prevention. So getting on a maintenance program to prevent these severe bouts where you need these rescue therapies, the Go Lightly or the gastrographin enemas, because those are harsh. It's harsh, emotionally, physically. So I really try to avoid those.
So we have time for one more.
One more. Okay. How does treatment of gastroparesis change in pancreatic sufficient CFers, specifically CFers in their 40s who need to lose weight?
So how does
The treatment of gastroparesis change?
I mean, the treatment of gastroparesis really depends on the symptom, sort of what symptoms you're trying to alleviate. So if the problem is that with the gastroparesis there's pancreatic insufficiency and the consequences of pancreatic insufficiency because the enzymes aren't getting there, then I would use medications to accelerate the gastric emptying, so Reglan, domperidone, Zithromax, and that would increase absorption. Now the weight component of that's a challenge because you don't want to cause malabsorption purely for weight loss, because then you end up with other nutrient deficiencies, the fat soluble vitamins, iron, calcium, which have other detrimental effects. We see weight gain and obesity in gastroparesis, which is interesting phenomena that we see outside of cystic fibrosis, that you have individuals who are throwing up, not eating a lot, and yet they're still gaining weight. And part of it, I think, has to do with dietary choices. So the low residue diet tends to be high carbohydrate, which promotes weight gain, as well as by changing the metabolic need, or sort of the metabolic set point. So, if you're chronically eating lower calories, your body goes into what I call starvation mode. It starts to try to retain all the calories that you are putting in. And then, with gastroparesis, it's an up and down. So there are days when you can eat more and days when you eat less. On the days that you eat more, the body's trying to hold on to that. So, for promoting sort of weight loss in that scenario, you want to avoid that sort of yo-yo, up and down eating, weight-bearing exercise, because by increasing muscle mass, you actually increase your calorie utilization even when you're not exercising, so when you're sleeping. So having more muscle mass in addition to the cardio exercising.
Thank you, everybody, for joining us tonight at our CF Discovery Series put on by CFRI Live. We are here at the Crown Cabana Hotel in Palo Alto, and we have had a wonderful discussion with Dr. Linda Wen, who has come to us from Stanford to talk about CF at the gut level. I encourage you to check us out in our archived broadcasts. You will be able to visit this again by going to our website. There's been a lot of excellent information tonight, and I myself will need to review to take it all in. This has been wonderful. We do have an evaluation sheet to fill out, and I want to alert you to our next CF Discovery Series, which is going to be on Tuesday, November 13th, when we will learn more about CF research how to participate in clinical trials, be a part of research. Our speakers will be Zoe Davis and Colleen Dunn from Stanford. We look forward to seeing you right back here in this same good location. So have a very nice evening, and thank you.